Hello everyone to this Dash Connect / ELSA meeting on medical AI inclusivity. Can everyone online hear me well? Good? Yes, oh perfect, perfect. My name is Mirjam Plantinga. I'm an associate professor here at the UMCG and I'm based at the Department of Genetics and the Data Science Center in Health. And I will be the host of today. And we have a wonderful program. Sorry, I first of all had to say, so this meeting is organized by the Data Science Center in Health and the ELSA Lab Northern Netherlands, but also by the Jantine Tammes School, the digital healthcare theme that the UMCG is leading. And we have a wonderful program. We have 3 blocks of presentations. We will start with Joelle Zwart. She is assistant professor in journalism studies at the University of Groningen. And also the digital lead in, or the lead in the digital inclusion theme of the Jantine Tammes School. Simone Goosen is a project leader at the Patient Federation. Hadi Hassan is working at Vluchtelingenwerk and he's also involved at the ELSA lab. And Patricia and Lisa, they are both also involved as researchers in the ELSA lab Northern Netherlands. I will give them the floor in a minute, but before I will do that, first of all, so this is me. First of all, very shortly I wanted to explain a little bit about the ELSA AI Lab Northern Netherlands. So this is a transdisciplinary consortium. We work together with academic partners, so the UMCG, the University of Groningen, the Hanze University of Applied Sciences. We also involve societal and business partners and public and patient representatives. And we aim to foster responsible AI in health prevention and care. And we do that by investigating ethical, legal and societal aspects. So we have ethicists involved, psychologists, people with a legal and socio-political background, and we also work together with artists. And we investigate the use of AI in different health-related decision-making contexts. And we pay a lot of attention to dialogue, communication, education. So, and I'm also very glad that we are here today to discuss this important topic of medical AI inclusivity. An important topic because we already know, and sorry, this is a picture which is in Dutch. I couldn't find an English one because they are always very often also about other countries. But I think, as we all know, there are differences in life expectancy between different socioeconomic groups. And these existing health inequalities, we know that they may increase with the introduction of innovative health technologies such as AI in healthcare. And therefore it's very important to pay attention to this inclusivity issues when you're developing medical AI systems in order to prevent that health disparities are widening. So that's why we're here today. We would really like this to be an interactive meeting, so we have both people here in the room as well as online. For the people online, please raise your hand or put a question in the chat if you want to contribute. We are very happy with your answers. We also have some speakers online who I will be introducing later today. Also maybe good to mention, I forgot to mention that, but this meeting is recorded and we will post it on the YouTube channel that of the UMCG, of the Data Science Center in Health, so also other people can also learn from what we discuss here today. To get you a little bit involved in this interaction, we wanted to do, because today is a Tuesday, and maybe some of you know this concept of dilemma on Tuesday. These are these 2 horrible dilemmas. You have to choose one of the 2. And we wanted to start a little bit by asking you to participate in that. And we also have some more AI-related dilemmas. So there's a poll everywhere. You can scan the QR code. Or either go to the website. And the first question or dilemma we wanted you to ask to choose between is, the question, you could either travel anywhere in the world for free, but every trip is randomly chosen by AI, or you could choose your own travel destinations, but then you have to pay the full price. So what would you prefer? Which dilemma do you choose? And in order to see the results, I think we have to change to another slide. because we can see your results directly.
And we also heard from some people online sound is not really good. Is this for everyone? Maybe you can. We heard from one person online that the sound is not really good. Can others maybe indicate in the chat whether that's also the case for them?
Well, I see it's quite evenly distributed here, so that's interesting. The sound is good. Okay, maybe I just have to make sure I'm speaking into the microphone. Is there someone here who wants to elaborate on the decision that they made? Who is in favor of traveling anywhere and leaves where he's going up to the AI to decide? Is there someone here in the room who decided for that option? You did, yeah? What was, so we have also this one. So we can throw it around, but I'm very horrible at throwing. So maybe we can do it in a few rows. I can send it to you and Natasha, yeah. So then you can elaborate on that. And then also, otherwise they, also back at home, at home they can hear it.
Yes. Yeah, I chose the first one. Is that fine?
Yeah.
Yeah, because I think it's interesting for me to just not to be prepared for a specific destination, and also it's free. So
yes, you like to be surprised, yeah, in that sense, yeah, and hopefully they will take into consideration that maybe they remove some of the countries where you definitely don't want to go through, and it's for free, so that's also maybe interactive. Yeah. And is there someone here who he says, well, I really want to have control on where I'm going, and then it's fine for me then to pay the price? Natasha?
Yeah, I intend to travel less anyway, so it doesn't matter.
Oh, yeah. So also for environmental reasons, then you want to stay maybe.
And you don't know where you end up, so how do you prepare?
Yeah. I can imagine. But it's very interesting that we are almost on the same page in that sense. The second one, just to get you started, every time you speak, it sounds like an AI-generated voice. Every time you speak, it sounds like an AI-generated voice. Or every email you send is automatically written in Shakespearean English. I don't know how to explain that. Maybe Joella knows well a little bit. Yeah. Oh yeah. To be or not to be, that's the question. Yes. Oh, but here's really so. Yeah, this AI-generated voice is a little bit So maybe you lose your personality a little bit. Yeah, I see people nodding here. Everything becomes the same. It's not interesting anymore. And Shakespearean English, that is it interesting or less bad? It could be funny. Here it's being mentioned, yeah. Any other remarks?
I think it's easier to avoid emails rather than speaking if you wish to see it as a bad thing.
Okay, yeah. Then you can see for other ways of communicating instead of email. Yeah, it's a good point, very good point. Okay, then the last one before we go to the speakers, also to go to a little bit to the topic of today, which is of course about inclusive medical AI. What would your favorite be? To develop an AI that never makes mistakes, but no one understands how it works? Or develop an AI that is fully explainable, but it makes mistakes 10% of the time? What is your preference? It's a little bit, I see a little bit more preference for the fully explainable one. Maybe there's also someone online who would like to give an explanation for the choice that they have made.
I just want to say that the slides are freezing. We don't see the result of the questions.
You don't see the AI dilemma now?
No, this screen isn't shared.
I still see travel anywhere in the world for
Sorry. Good that you mentioned that, Hadi. So we shared the other. Now you can see it. Yeah. So this was. Here, then you see the results. So this was the first one. Both were almost equal. Can I now? This was the second one. So a very high favorite here, and this was the last one. It goes a little bit slow. Yes. And Hadi, what did you choose?
I did choose the first one.
The first one.
Yes, never makes mistakes. I think no one, definitely some people would understand how it works. So, but if no one, yeah, it's a tricky question. But I would prefer an AI that never makes mistakes, especially if we are speaking about in a healthcare context, maybe, or defense context. You never know.
Yeah, I can imagine. Is there someone else who voted for the other option? Who wants to elaborate on that? So, yeah.
I was thinking in terms of a power outage. So then you don't know what's going on with the AI. If you've been using it for a long time, similar to like a TomTom in a car, if we rely on AI for that sense, and in case we don't have the ability, then we can still use the knowledge underneath to design or to decide ourselves rather than.
Yeah, so that in the future, indeed, it would be possible that we as humans then would make more mistakes if we somehow indeed the AI doesn't work anymore, or we can't control it in a sense. Any other remarks?
I chose for the first one, mostly because we as humans don't understand how we decide anyway. So I think it's overvalued that we need to understand everything in AI.
Yeah, there's a lot of discussion, of course, also on explainability. What do you mean with fully explainable? So we won't dive into that in detail, but maybe I think it will be brought forward in some of the presentations today. So this was to get you started. Now I would like to go to the first speaker, and I think I have to share my other screen again. I will do that. So the first speaker I would like to give the floor is Joelle Zwart. As I mentioned, she is the team lead in digital inclusiveness at the Jantine Tamme School of the University of Groningen, and she will elaborate a little bit more on this concept on inclusiveness. What is it, and what does it mean for AI in healthcare? I would like to give the floor to you, Joelle.
Thank you so much, Miriam. I hope that everyone online can also hear me. Maybe they can post something in the chat or give a thumbs up, if not. So thank you, Miriam, for this invitation to talk to you today a bit about the concept of digital inclusion, inclusiveness, and how to relate it to AI in healthcare. So as Miriam already mentioned, I am not a medical doctor, haven't worked in healthcare, but I am a media scholar. I do a lot of research around the topic of digital inclusion and digital literacy. So how do people develop the skills and the knowledge to deal with digital technology in a society that becomes increasingly digital? And that's something that affects people in many areas of their everyday life. So I do a lot of work with schools, for instance, in education. How can we teach children to deal with digital technology? But also with groups like people who have trouble reading and writing, so low literate people, and how we can teach them and help them to deal with digital technologies, for instance, also to simplify difficult letters from governments, and so on and so forth. So I work with very different target groups and in many different contexts. But I'd like to use this opportunity to speak to you today a bit on this topic of digital inclusion, the concepts that are often used in my field, so more in the social sciences, to see what aspects of those could maybe be helpful also to address challenges of the implementation, around the implementation of AI in healthcare. So just to get started, talking a bit about what I do at the Jantina Thomas School. So if you know it, it's an interdisciplinary research school at the University of Groningen that tries to connect different faculties at the university, including the UMCG, with the mission or motto, digital prosperity for all. So how can we create a society in which everyone can enjoy the benefits and defend themselves against the risks of digital technologies and AI in the current society. However, as for instance the Central Bureau of Statistics points out, despite a country like the Netherlands and a city like Groningen being very digital, so lots of people having a broadband connection at home, lots of people owning a smartphone, there are still 3 million Dutch citizens, and that's about 1 in 6 citizens in the Netherlands who lack basic digital skills, who, for instance, have trouble sending an email or who have trouble navigating a website with health information. So that means quite a large gap in digital literacy, but also many populations, many groups in the Dutch population and also worldwide who aren't included in many of the digital innovations that are currently being developed. And what's more important here is that this digital inclusion often overlaps with all kinds of social inequalities that we've been seeing for many, many decades. So for instance, low digital literacy tends to intersect with people who also have chronic health conditions. People who are often low digitally literate often have a lower socioeconomic status. They're more likely to have a migrant background, they're more likely to be older, etc., etc. So there's quite a lot of overlap between these two groups, which means that whenever we think about adoption of new technologies, and this is true for digital technologies, but also for many AI applications, we should also consider these social inequalities. So this is a major societal challenge, I think also very much a political issue that affects a large group of the population. So often we think about elderly people when we think about people with limited digital skills, but it's a much larger group, 1 in 6 in the Netherlands as a relatively digitally advanced country. So how can we create these conditions in which all citizens are able to fully enjoy the digital society? And when we bring this question to the field of healthcare, the question then becomes, as AI becomes integrated in healthcare, how can we ensure that all patients can reap these benefits of these AI tools, and ideally also minimize instead of continue to prolong systemic healthcare disparities between different groups in society? Because of course many of the things around social exclusion that I explained also relate or also overlap with all kinds of health disparities. So I wanted to show first a couple of concepts from my field that I think might be relevant or helpful for the discussion later on, also with the other speakers, and then move to a number of challenges that I think would be important to take into account here in our discussions as well. So first, related to the question that I just showed you, in the field of digital inclusion, there's often talk about equality, but increasingly we see a shift to the concept of equity. So the difference between the two, I think you can clearly see in this picture. So when we talk about equality and inequalities, it's often about certain interventions that are given to everyone, the entire population, which then bring everyone one step up, right? Which is often how these technologies are being spread. But that kind of ignores how not all of us have the same starting point. Some of us may be more prone to certain health conditions than others. And this difference in starting points, living situations, is why within the digital inclusion fields, more and more scholars look at questions of how we can promote equity. So recognizing these different starting points so that in the end, everyone can achieve the same outcomes, as you can see on the right of this picture. And I think this is also quite apt when we talk about AI and the effects that it has on healthcare. So how can we move to a situation where the outcomes in terms of health are similar and hopefully as positive as possible for everyone and maximize these health benefits? So this is one concept that I wanted to introduce. The second one relates to adoptions of innovation. So maybe you know this model. This is the model by Rogers about the diffusion of innovations, where it shows that there's always, for every innovation, a small group of people who are really enthusiastic about the adoption of new technologies. Think, for instance, about doctors or healthcare professionals who are really interested in trying a new tool. Then a relatively larger group of early adopters, an early majority. But then there's often a lag in time before also the others start to get engaged and adopt and implement new technologies. And this has to do with a number of divides. So that's a model by Van Dijk and Van Deurzen, two scholars from Twente University. And they talk first about a divide in digital terms related to material access. So that's people maybe not having a broadband connection that's fast enough to use certain tools. You can also think about not having a computer or not having a smartphone. Think about two-factor identification that some digital technologies, for instance, require. If you don't have two devices, if you don't own them, it's difficult to use certain technologies. We have second-level divides, which relate more to differences in digital literacy. So how skilled is everyone to use technologies? How much use do they actually make of these technologies? But also quite important here is the third-level divide. And that's more, so when we have the access, when we have the knowledge and the skills to use certain AI technologies, for instance, as healthcare professionals, how do we also ensure that there's no longer a gap in things like acceptance of technologies, trust, being able to assess the impact of these technologies in our everyday practice? So I think these three levels also give us some lenses to think through this implementation of AI in the healthcare field as professionals. So let me then move on. Great, thanks. So let me move on to some challenges then around inclusivity of AI in healthcare here. I hope it will, So first of all, of course there's many questions in AI decision making around bias, right? So I was already talking about disparities, social disparities, existing health disparities between different groups. For instance, around socioeconomic status, but also gender, ethnicity, and so on. How can we ensure that AI makes fair decisions? And there's lots of debate around this, especially when it relates to the underrepresentation of certain groups, for instance, in user testing, in clinical trials, compromising the generalizability of different AI solutions. So how can we ensure that different social groups can enjoy the benefits of different AI solutions? For instance, this is one of the cases from the field of education. So you might be aware that at some point at the university, or the Free University of Amsterdam, there was quite a scandal around the use of proctoring software. So students during the COVID crisis were obliged to use a monitoring tool to ensure that they were working on their tests without using any other sources that weren't allowed, such as going to Google to find the right information, not using books or whatever, to cheat during their exams, and they were required to use this proctoring software when they were using their testing environment. And the software, when one of the students tried to log in, flagged her as, well, not properly behaving as a student taking the test, right? And it turned out that this AI solution wasn't able to scan her face correctly because he was wearing glasses. These kind of discrepancies or these kinds of faults are things that you obviously want to avoid, and that could be avoided with a broad range of user testing. You can also imagine, for instance, Let's say that you would have an app to scan moles, for instance, to check whether it might be a melanoma or not. And these apps that you have, these are apps that should also take into account many different factors around skin colors and so on, to make sure that no disparities and no inequalities or inequities may be exacerbated. This also, beyond user testing, means thinking about the selection of metrics that AI uses for decision making. So what kind of metrics do we include in these models, and what does that mean? What kind of impact might it have? And thinking about potential geographical distortions. So AI technologies are developed within a certain context by developers who are used to a certain national or cultural context. What does that mean when AI tools are then being applied in a different context? What kind of assumptions are hidden within these AI models? All these are questions to think about when you think about AI decision making and the implementation in healthcare. So many different questions, I think, already here. The second challenge that I wanted to talk to you about relates to this third level divide that I was talking about. So acceptance and trust in AI decision making. So how to make sure that we build trust and increase acceptance of AI technologies among patients, but of course also among healthcare professionals. And I think it's good to mention that, of course, this also depends on reliability of these tools, right? But let's assume that you have a tool that works quite well, that has makes relatively reliable decisions. Then still there's many concerns to take into account. For instance, around privacy, especially in healthcare, there's lots of sensitive information being shared. And it also means that sometimes you may need to take decisions that might require you to think about, okay, if I share this information now, what might that mean in the future? For instance, if I want my child to have the best treatment and there's an AI involved in that, and I share this information about my child, what will it mean in 10 years when that kid might have to apply for health insurance? Could that data then also be used in different ways? And how do we make sure that this is only used within this particular context, right? So there's many questions around this, especially because of an increased risk, as many scholars here point out, a risk of identification of AI detection of unintended patterns. So we give data about certain parameters, and the AI may also identify patterns that we did not think of before. I think one of the key examples here is, for instance, the example of the Target supermarket in the US, where a teenage girl was buying products, and Target concluded she must be pregnant and started showing her advertisements for diapers and other products. And then her father got really upset, called the supermarket and said, well, this can't be right, she's only 16. And it turned out that the daughter indeed was pregnant, so the algorithm had correctly predicted her pregnancy. So you can imagine how similar patterns might exist or might also turn out for healthcare applications, and the risks that might bring. So we might not always, as humans, be able to predict what kind of unintended patterns an AI can find out about us. There's also issues to consider around data ownership and autonomy. So who decides exactly whether to use an AI for your treatment, yes or no? Who needs to be held accountable for decisions when an AI is being part of that process? Is it a doctor? Is it the developer? Someone else? So many questions around ownership and autonomy as well. Thirdly, what does informed consent here exactly mean? And especially with patients who may have lower levels of AI literacy. Can we, or should we expect people to have a certain basic level of AI literacy when they need to make decisions about the use of AI? What about doctors? How do we make sure that they are AI literate enough to make an informed decision about the use of these tools? It requires quite a lot of knowledge, and the question is, how can we ensure that everyone stays up to date on this type of knowledge? And finally, I think it's good to point out, especially for an international audience, there's also quite some differences in AI policies and regulations between countries. So in the EU, we have the EU AI Act, but that might be different in other contexts. So what about technologies, for instance, in healthcare that are being developed in the US, which has a different regulatory context, which might then also be implemented in other countries? How do we deal with these international differences? All right, given the time, I'll move on to the third challenge that I think is impossible to discuss. And that has to do more with the accessibility of these AI-driven solutions and how to build AI literacy, so the second level divide that I showed you, of healthcare professionals. Because of course, AI tools that we create should be accessible and user-friendly to a diverse group of users. That's good for patients, but also good for professionals. And ideally, we want tools that do not replicate or enlarge, and especially not enlarge existing digital divides. So think, for instance, about telehealth solutions that can be a good response to current deficits and the current lack of healthcare professionals. If we want to promote these kind of tools, that means that we also need to take into account the needs of a diverse group of individuals. Maybe in certain countries it's not as common to call with your video on, but audio might also be a solution for certain healthcare questions. So whatever tool we're adopting and we're spreading needs to take into account the different needs and nuances of the different types of users and communities that use it. But also from a healthcare provider perspective, how can we keep facilitating the AI literacy of doctors and other healthcare professionals? And I think this especially is the case for people who are already outside of the scope of education. How do we continue to do that? It's relatively easy within the context of a medical curriculum, but what to do with everyone who is already working in healthcare as a professional? How do we make sure that they also stay up to date about these matters? And what types of AI literacy, so what kind of knowledge or skills do we then prioritize in these kind of programs? So also many questions there. So how to move forward? I think one first step is indeed things like these, where people from different disciplines meet. So making sure that healthcare professionals meet people with medical expertise, with AI developers, but also thinking about, okay, what does that mean legally? What kind of ethical questions do also connect to this? And how can we also develop policies around this? Setting clear regulatory frameworks that address these ethical, legal issues, all of these challenges and complexities that this implementation of AI in healthcare introduces. Regular evaluation and monitoring of the tools that we are already implementing. So are they reliable? Are they safe? Are they effective? Are they also having the effect that we aim the technology to have? That's also important, and this may also be more challenging at relatively small institutions where there may be less financial means to make sure that this monitoring regularly takes place. And finally, a timely involvement of a broad range of different patient groups in clinical trials, in user testing, and ideally also from the start of the project, from the process. So that's also why I think it will be interesting to later on discuss more about co-creation methods and how this could be done in practice to hopefully avoid exacerbating pre-existing health disparities. I'll leave it at that. Thanks for your attention, and I'm looking forward to the discussions later on.
Thank you, Joelle. Before we go to this AI dilemma, are there questions for Joelle? I think I will stop sharing for a minute. Either online or here. Maybe one question from my side, because you're really an expert also on this digital literacy. Now you also talked on AI literacy. Mm-hmm. What do you think is there a difference? What is the main difference or the main challenge maybe? What can we learn from the digital literacy field?
Yeah, so I think one most important thing is that I think AI literacy and AI divides build upon those digital divides. So there's already within, well, relatively easy to understand digital technologies, quite some differences in both access, in use, but also understanding the impact and the trust of digital technologies. And I think the lessons that we can learn from that are important to also take into account when implementing all kinds of AI tools. So for instance, the importance of different user testing with a variety of groups, taking into account all kinds of social inequalities, not just thinking about access to a tool, but also making sure that these tools are easy to use, because accessibility is one, but ideally you also want something that's easy to use, right? That's user-friendly. That trust is such an important thing for adoption of new technologies. So all of these different dilemmas, I think, again, come up for AI and for the implementation. So I would say that AI literacy builds upon the digital literacy discussions that we've already been having for 2 decades or so. And well, whatever inequalities and inequities we see there, that's quite important for most AI tools as well to take into account.
Thank you. Thank you. Very useful. Thank you for this laying this framework already for the talk of today. Yeah. Before we go to the next meeting, we wanted to have another dilemma. So I have to share the correct slide. I think this is the correct one. This one we already have. Now the next one. What if you can instantly learn any new language, but you will forget a random existing language each time? Or if you would be able to speak all languages you are currently able to speak, but you never learn a new one again? So do you want to... I have to press present, sorry. Now you can vote. So, do you want to learn new things, but you will forget also a language each time? Or do you want to be able to stay with what you already know? I think the majority here is in favor of not forgetting a random language. Might also be a little bit difficult. I thought it was also a nice bridge to the next speakers. So for the sake of the time, I won't ask for any clarifications, but it's interesting to see that we are scared of losing randomly any existing language. And the next speakers are also a little bit the patient and the public perspectives, as already Joelle mentioned, very important. Simone Goosen is here from the Patient Federation. She's a project leader there, and she has a lot of experience with language barriers that are faced in practice. And Hadi Hassan is working at Vluchtelingenwerk and also at the ELSA Lab Northern Netherlands as a researcher investigating migrant perspectives towards AI. Simone and Hadi, welcome. You are both online. Thank you very much for being here. And I think, Simone, you will start first, and afterwards Hadi will join, and after the both of the speakers, we will also have some time for discussion. So may I give the floor to you, Simone.
Yes, thank you, Miriam. Can you hear me properly?
Yes, perfect.
That's perfect? Okay, thank you very much. And I would like to share my screen. I don't think you see my screen yet.
Yeah, we see it, but not in presentation mode yet.
Not in presentation mode yet, okay. That's right. I have to switch to the... Sorry for that. Presentation mode is now on, I think.
Yes, perfect.
Thank you. Well, thank you for inviting me, and I'm very happy to share this presentation with Hadi. We are both very much concerned about what language barriers do mean in healthcare for those people who have come to the Netherlands either as a migrant or a refugee. And well, I'll try to explain a bit on the work that I've been doing in this field, and more digital translation tools are part of my work. more on the medical interpreter aspect. I'll start with a video to show you one of the consequences of language barriers that are not properly taken care of. I hope the sound will work. I'll try.
Alles lijkt in orde. U kunt vergaan.
Kan ik doen?
Kan ik het zo sarwale kappa?
Yes.
Wat controle appa? Het lijkt goed te genezen, maar ik zou nog even rustig aan.
Ik had een rust. Oh, nee. Wat je mag te lopen, nog. Trouw je ziek als dat?
Ja, het is het صافي.
Uit de CT-scans is gebleken dat u ernstige uitzaaiingen heeft. Ik vrees dat we niet veel meer voor u kunnen doen.
Great. Children having to do the translation for friends, family is one of the very bad consequences. It really leads to trauma, it leads to badly translated situations because children do not know what the impact of the consultation is, or they don't know the words, they feel very stressed. And so it's one of the things that we really want to stop with the campaign we're working on, but then the question is, where are the solutions? Digital translation platforms and tools are based on AI, and then we will see what happens. The quality is not always as good as what we would want to, and then we get to a lot of confusion. And this one, sorry for, the fact that it is Dutch and Arabic and all the languages together, but in fact the youth medical doctor who showed me this picture, she just asked the mother to go and collect pots for urine determination, and she did that after having worked with an interpreter, and she said, okay, but it shows clearly how much difficulty we have to really get to the point. About meeting, I will introduce the campaign in our guideline project and relation with digital translation tools. Hadi will will talk about assessing influence of AI translation tools and the first results in his PhD study. I will look at the main recommendation of the guideline that we have just launched on addressing language barriers in health and social care, and then we will hopefully have some time for challenges in machine translation. Well, it is AI. I think many people do not know that, in fact, the machine translation tools work with AI models, so that's already an important thing to keep in mind, I think, because they will not have the awareness that we really want people to have when they use AI. There is a lot available, and people are using it more and more. We hear a lot of people and hospitals looking at what could be used, but there's still a lot of questions. There's no policies in this field, and I will just share with you later on what we will do in the guideline. One of the things that I wanted to show on the left first is that a lot is being used simply by mobile phones, for example, and we also see the small machines being used specifically for the translation work in hospitals, in family practices, in all kinds of healthcare facilities. I'll skip this one because Joelle already addressed it very properly, I think. And in fact, that's what my work for, on the one hand, the Patient Federation, but also for the Johannes Weir Foundation on Healthcare and Human Rights, is really based on. It's about improving healthcare and really looking at possibilities to stop the inequalities, and language barriers is an important factor in this. What happened in the Netherlands with respect to language barriers in healthcare is something in what we call toleration cabinet Wilders, gedoogkabinet Wilders, and they decided to discontinue the free access to interpreters in healthcare. And despite a lot of protest based on our health laws, which really already at that time really made it the responsibility of the health professionals to properly inform the patients and also have informed consent on treatment and treatment choices and so on. Despite that argument by all the main professional associations in the Netherlands, the Ministry of Health continued their step to stop this funding, despite the fact that it was about only, well, it was about 20 million euros per year at that time for all these services by interpreters, but well, difficult to stop the policy development. And in fact, we are still working on getting back to access for all health and social care professionals to have access to medical interpreters. We did a legal study with a public litigation group because we wanted to try this from, to address this from the legal point of view, but in the end it was very difficult. In fact, the policy part is easy, but addressing the cost is very difficult if people are not using interpreters because they do not have access. This is the main theme of our campaign. Language should not be an obstacle, right? And interpreters back in healthcare. We do inform health professionals about how they can get access, because in several fields there is good access to medical interpreters. There's also access for all healthcare professionals and social care professionals to in asylum seeker center, as well as for refugees from Ukraine. So what we try to do is, well, help by using the available options to work with interpreters, and also, of course, look at the other ways of bridging the language barrier. That is, that can be family members or friends that help people with translations, but it should never be a child. And that is what our poster campaign says. This is a child, this is not an interpreter. And so we also, again, want to help this out. Well, then about the work that I've done over the last 3 years for the Dutch Patient Federation, that is to lead the Zonneweg funded project to develop a national level guideline on mitigating language barriers in health and social care. The Patient Federation is, in fact, the only organization that can develop guidelines in the official way in the Netherlands that are an umbrella or really cover, let's say, all the fields of care. So a very nice place to work on this topic. And we've worked with a lot of the main professional organizations. We've been able to work with very good researchers from Amsterdam University, specialized in language barriers and communication in healthcare in a broad sense. And in fact, what I wanted to show is that in the guideline project, we also, of course, involved a patient organization, and they set up focus groups in various places in the Netherlands. study carried out by a consultancy firm called Equalis, commissioned by the Ministry of Health, and they did a first inventarization of health professionals' views and patient views on digital tools for mitigating language barriers. And we worked together with Migration Inc. of Jordi Lassoy for this project. Well, for this meeting, I think it's interesting that the conclusion of both projects is that the digital tools are only suitable at this time for simple situations, when making an appointment, or very easy meetings where it's very clear what the patient's need for care is, and in situations where maybe already the person does speak quite a bit of Dutch, or there is a common language with the healthcare professional like English or French or Spanish, Turkish, whatever, then also it can support. Everyone is very clear that digital tools cannot be used in important conversations such as diagnostic interviews or intake interviews, or when the topics are very sensitive or with important consequences. Then, in fact, what is also mentioned is that, of course, there's a very big differences in the degree of literacy, a general or digital literacy between the patients. So that's what people really want to be taken into account. When we have more and more voice translation possibilities, that becomes maybe a bit less. But I think we really have to look into this very, very well. And I'm happy, very happy with the studies that Hadi will work on in this field. So I'll switch and give the floor to Hadi.
Thank you so much. So just very fast to give you a bit of background of me. So I'm a researcher by Vlottenwerk and also a researcher by UMCG. I received the Hestia funding to work on the newcomer's perspective in the use of AI in healthcare. By Vlottenwerk, I researched the digital inclusion, just to give a bit context very fast. So Vlottenwerk is our Dutch Refugee Council, is the biggest NGO that guides refugees in the Netherlands. We have 200,000 clients, half of them are Ukrainian. And since the beginning of this year, we have a budget cut from the government, so we decided to digitalize all our services. We used to do this face-to-face in 350 locations. In 2 months, we have to close 300 locations. In my research, I'm applying a human rights approach, which is AAAQ+, which is availability, accessibility, acceptability, quality, plus it could be also the privacy and informed consent. I'm also focusing on assessing the influence of language barrier and AI translation tools in the journals of the right to healthcare access. Yes, so what I will do today is I will present a bit of insights and data, what we've done by Vlottenwerk, and also pilot tests that I've done for ELSA Lab. By Vlottenwerk, we've done 2 large survey conducted in 8 different languages with 2,300 participants. And just to be clear, this just only were recruited via social media channels and online. So it's not, we didn't go to the location to do this. And for the ELSA Lab, we are now building a survey, so we'll only in Arabic, and we will aiming for 385 participants across the Netherlands for Syrian refugees, as again to assess how language barrier and AI tools can influence the enjoyments of the right to healthcare in the Netherlands. Next. So this is one to start for a bit of insight in the data that what we've done by Vlottenwerk. So we started first to understand which factors can actually influence those people using this digital or services that we can provide. So we did it in 8 languages, but I will share it now with you. First, in this slide, the 5 languages As we see here is that Turkish, so it's not Turkey as a country, but Turkish participants show the highest digital skills or literacy across all 5 categories, and the categories that we used back then also, one of them is not here, is that you have access actually to internet, you have access to laptop or smartphone, can you edit documents online, can you do digital contracts or communication, can you share files also online or film forms for IND or any other institutions, and can you search independently for information by yourself or online. And as, okay. No, before. Yeah, the other thing that was what we see that Syrian and Persian participants have shown the lowest across these 5 countries. Next one. So, yeah, one of the questions that what we wanted to do is that we can make a lot of videos in the future, because as I said, we provide a lot of information. This guidance or supervision made only face-to-face, and to digitalize this, we are also exploring to use AI in this field. So one of the questions is that do you prefer a real person that speaks in the video in your language, or real person in another language like the Dutch with subtitles, or generated AI videos? And as we see across all these 3, we see that they would choose for a real person in their own language. And the generated AI videos are less preferred also across all these languages. Only that we see that Syrian would prefer to have a Dutch with subtitles. Next. Yes. Yeah, again, but just want to show you from here is that Turkish, who scored the highest in their digital skills and digital literacy, is the only group who have, relatively 30% have chosen for AI voices. But in the end, as I shown before, that they all still prefer a real voice, a real person speaking, not an AI. Next, please. Yes, and the question of the trust in AI videos. So this is also on AI-generated videos or tools. So as we can see again here, the Turkish, who also was scored the highest in their literacy, digital literacy, they tend to have more trust compared to other groups. And but still, the Ukrainian and Syrian who scored less, they are neutral, so they don't have a very fair mixing. Next, please. Yes, so what are the main concerns for them about using AI informations? And what we can see, their group, they have different also concerns. So Turkish also scored again, they have their main concern is misuse of their data. So privacy is the main concern for them. And Ukrainian worry more about misinformations that can get from AI, and Syrians is also so that wrong translation or also misinformation from this AI tool. Next, please. Yes. So about the question, what you prefer, which way to receive the video explanation? Again, but here is the comparison that is not based on countries of origin, but based on the factor of high digital skills or limited digital skills. Again, this also shows that most, also from both groups, prefer a real person in their own language. And people with higher digital skills still would accept more animated videos or AI-generated videos. Next, please. Yes, so this also divided based on their digital skills. Both they have high neutral, but what we see here is that the limited digital skills, they have high level of no trust at all. highly digital skills for them is the impersonal voice, and yeah, all of them, the three highest is then misuse of my data, wrong translation, or incorrect information that can be provided. So for both groups, but what we see also that the higher digital skills or higher literacy, they have, yeah, they scored almost 20% with no concerns at all. Yes, this is also what we've shown before, is that between them, they still prefer divided between high digital skills or limited digital skills, prefer real voices. Next. Yes, so this is the pilot test that I did for my research by ELSA lab. It was 45 participants recruited via social media. They are Arabic speaking. So the question was, if you have needed or used a translation tool or translation assistance in the Netherlands, what type of translation did you use? So 30% of these participants have used digital tools such as ChatGPT or Google Translate. 70% have also, yeah, they went with the human interpreter. Either is, I didn't make a differentiation between here is between a professional, so they were given a talk, or a friend, or yeah, someone they know. Next. So yeah, most, approximately 75% of the participants have been living here for a short time, so for 1 or 2 years max, and the rest is 3 years or more than 3 years. Yeah, what's also interesting from these participants, Syrian and also as Arabic-speaking participants in this survey, most of them, their highest level of education was middle school, so the 8th grade, and yeah, and the rest 44 we have is higher education, so MBO and HBO, etc. Yes, so in this pilot test we had, I have asked different questions, mainly to see the differences in people answers between the human interpreter and digital tool. So as we see in the questions that the doctor or nurse or the healthcare provider understood me well using this method, we see that the human interpreter have scored higher score in general than the digital tool, and the disagreement is higher also by digital tools. So in general, that the in terms of understanding or what they perceive that they were understood were is for human interpreter is higher. So according to them, what the question is about the medical terms, if they were translated correctly, again, we see that the agreement, like they strongly agree for human interpreters, we have nothing for digital tool. They also close to each other in the agree, but in the disagree, we see also much higher for digital tool comparing to human interpreter. Next, please. Yes, for the question, I felt confident in the translation method. So the respondents felt more confident using a human interpreter, both in the agree and disagree, and a higher disagreement for the digital tool, both in disagree and strongly disagree. Next. So I felt this about my privacy, and then I felt my personal information was protected. This is the only question that we actually, which is also interesting to see, that the participants who use digital tool, they also scored high in both agree and disagree, and very limit in disagree and strongly disagree, which is interesting. And this is also lead to question is, does the different settings in healthcare would also impact? So is that your visit by a house arts or mental health care or yesterday diagnosis treatment plan, and we again here see that the human interpreter is also scored more, but also at the same time, it's we have also for the strongly disagree that the human interpreter is more than the rest. So in between. Yes, so the question if you are willing to use or choose this translation tool or method again in the future, again is that the participants with human interpreters were more likely to choose the same method again. So, and they also, both of them scored almost the same for strongly agree. But for disagreement, we still see that the digital tool scored higher compared to human interpreter. I think this is the last one from my side. Yes, I give the floor again back to Simona.
Yeah, thank you. I don't know whether there are maybe questions for clarification to Hadi. Miriam, maybe you can.
Yeah, maybe for the sake of the time, we can finish with your talk, and then we go to the questions. Yeah.
Yeah, that's great. I just wanted to share with you, let's say, the main element of the guideline. And in the basis, we really let's say, set it up in line with the kind of conversation type. That was already the case in the old, what we call kwaliteitsnorm tolkgebruik, where we have a similar formulation of like for complex, sensitive or impactful consultations, conversations between patients and health or social care providers, you would either need an interpreter, and that's always in the guideline. Interpreter means a professional interpreter. An informal interpreter is a strange coding. We don't talk about informal doctors, nurses, whatever. So we stick to the interpreter that's a professional or a healthcare professional that can provide the service in own language. So not the use of a healthcare professional as an interpreter, but really handing over the patient either in the own institution or care facility or to another in order to provide the services. Then, if the conversation type is easy or less complex, asking a relative or friend that came with the patient or client is possible. A digital tool is an option, or if the two options above are not either resulting in a good conversation or not wanted by the patient or the healthcare professionals, you can still consider the interpreter or the healthcare professional in own language. Well, this is a very framed way of looking at it. In the end, it will always depend on do you understand each other, and therefore using the teach back method, where you really find out whether you do have the same understanding, is very important. And also what we want to stress with the guideline is that the choice of the method to bridge the language barrier is something that you need to decide together. Well, easily said, but maybe not always easily done. But even that could, for example, be addressed by using a digital tool before you start the real conversation. I just want to go back to the topic of this afternoon, and that is that we have, in my view, and also in view of many people abroad working on this field, for example, Lynn Bouke, we have really have to take care of people being aware of what machine translation means in situations as important as language barriers in healthcare. So really make people people aware of this, make people think of whether the text is sensitive or private. This is about translation, but the same goes, of course, for the verbal aspect. What are the consequences? That is, in fact, in our guideline as well. And if you talk about translated materials, which is, of course, also very important, will someone check before it's being shared? And then, is there an urgency? Is always important to consider, and that is, well, when, for example, you could choose, according to the guideline, even in a difficult situation, to use machine translation. But again, taking it into account what the difficulties will be and what the errors may be. I mean, I would like AI to develop in such a way that if AI doesn't know the translation, that it states that it doesn't know, or whether it's unsure, or give a certainty level or whatever, because then we would be what? I mean, that's what a professional interpreter would do if they don't understand maybe the explanation by the doctor is too medically worded. Then an interpreter would ask, well, please, can you explain it in other words? That would be a huge step in machine translation, in my view, if uncertain situations would not result in the example that I started with. And something that we have to keep very clearly in mind, and that we haven't addressed well in this short presentation about the topic, is that the quality of translations are very, very different between the different language pairs. So English Arabic is better than Arabic Dutch, but English Dutch is much and much better than Arab Dutch or Tigrinya or Farsi or Dari. All the languages that are less commonly used worldwide. In fact, there's less training materials, so it will take, according to the people working in this field, still a lot of time before, and maybe, well, will it ever be available at a level high enough for medical translation? That's really the question. And what I see happening is that there are companies that are now, well, pretending to offer these translation services. They say, well, we have available in 80 languages, but there's no statement at all about the quality and what is or what isn't possible at this time in this field. And then, well, let alone the languages that are not written languages or local accents, for example. But there are really chances as well. I hear more and more hospitals that are really looking at a policy for language barriers in their hospital, or expanding it towards the digital translation tools. And there are also a few companies that really focus on medical translation. And a good example, in my view, is Care to Translate, a Scandinavian company, and they have both the option of, let's say, the free translation, which is also based on AI models, or a checked translation for standard questions and answers, which they developed with human checks of the translations. Well, I'll stop the presentation.
Thank you, Simone and Hadi, for your presentation, your contribution. I think it's very insightful to see this enormous language barrier and how digital tools try to bridge that gap, but they don't fully succeed. Are there any questions for Simone and Hadi, either from the room here or online? Michiel.
Yeah, I have a question about the the translation machines you used. You were DeepL and another. Did you also try the new large language models, how they work or not? Are they better? Are they not better?
Did you get that question? So it depends maybe also a little bit on the type of models behind the translation machine. So the large language models, they might be better than the yeah, how do you say that?
A bit older
Yeah,
models.
the older models, which is just copy and pasting. I think the how do you say that? The book, the translation book. It's not based on a large language model. Do you have any experience with that?
Yeah, well, I'm not using it personally. I'm not a care provider, but of course there's progress with the large language models, and we see differences. I mean, DeepL is still considered of higher quality than, for example, Google Translate, but they also are. Well, DeepL has less languages available, and it's still very difficult for people to know what the quality is, and all tools, whatever model is being used, really can only improve if there's training data, and that's a very, very big issue and a difficult problem because, well, as it's not being used that much, there's less training materials. If there's less investment in language combinations, there will be less progress. So, for example, Dutch Arabic, by one of the owners of one of the companies, he said, well, it will take us at least 5 years before we achieve sufficient quality. Sorry.
Yeah, I think it's a very important point that indeed, as we know, the more data, the better the model you can develop, and that will be a problem indeed as well. So, yeah, I think an important point, and I think interesting to consider indeed all the aspects. What I also found interesting was also from the results that you showed, Hadi, is that first of all, I think, yeah, the difference between the real voices and the AI-generated voices, that's also something that's going to disappear a little bit, I think, maybe with the new models. And also that a lot of people did not understand AI. So in that sense, I think there's a lot of ideas about this new technique, and that also, yeah, maybe that can skew a little bit the results, that they think, well, I'm not sure about AI, I prefer the human in a sense. So I think there's also a lot of work to be done in terms of yeah, getting people more literate about what it actually is. And yeah, good also that you mentioned that the necessity of developing this critical notion of indeed correcting and be aware of yeah, the fact that not all outcomes of these models are indeed true or correct. Simone, something to add?
Yeah, just wanted to add that because you're in light of Hadi's results referring to the patients, but also for healthcare professionals, there's really a lot to gain with awareness on this topic and what is possible, what isn't possible, and also, for example, with policies that explain to the staff what can be used or what can't be used. And what is very interesting currently, in my view, is that, well, there's several hospitals who've been working on this topic, and they all three end with a different choice. So there's one choosing for Google Translate, one choosing Microsoft Translate, and another hospital DeepL. And then only one of the hospital really limits it to the use on telephones owned by the hospital. And that same hospital also does combine it with a project to have translation machines, as not all staff will have a telephone from the hospital. So I think that there's huge steps to make, and our Dutch hospital associations, the NVZ, is preparing, and I'm preparing with them, a webinar to bring people together to think about this and share experiences, because we really, well, we know that there's a lot to be gained. I mean, what I say about being careful and the risk and the limitations, I do not want to say that you shouldn't use it for the simple contacts. It's just that we have to find a balance and have a good way of call it instructing or guiding staff and patients alike on what are the gains and what are the risks or pitfalls of these tools.
Yeah. Yeah, thanks for this addition, Simone. We have to focus both on the patient perspective but also on the professional perspective. Before we go to the last block of speakers, we have another question for you, and that is this one. Would you favor implementing an AI that reduces bias, but it takes a year to make decisions, or implement an AI that makes decisions in a second, but can reinforce existing inequalities? Curious to hear your thoughts. So I think it's a little bit of a combination of both. I give you some time to. So I think most people will choose to reduce bias. I can also imagine that, given the topic of today, that's wise. But indeed, when it takes too long, that's of course also problematic. We won't go to that in detail, also for the sake of the time. I would now like to give the floor to the next speakers. I'm just going to look for the correct slides. Is it this one? Yeah. Oh, I'm too far, sorry. Yes, so the final block of speakers are Lisa Ballard. She's from the University of Southampton, so she's with us online. And she is also a research fellow, a visiting research fellow at the ELSA Lab Northern Netherlands. And Patricia Pita Ferreira, she's a PhD student at the ELSA Lab Northern Netherlands. And they're going to explain the results of a workshop that we organized in the beginning of this year as an ELSA Lab on how can we realize inclusive medical AI. And I think, Lisa, you are going to start first, as I understood. May I give the floor to you? And then I think you're going to share it yourself, are you, Lisa?
Yeah, I can share my
Yeah,
slides.
okay, I will stop sharing then.
There we go. I'm just going to move you out the way. So thank you, Miriam, for your introduction. So I'm Lisa Ballard, and I'm going to talk about a project and use that project as an exemplar of how the ELSA Northern Netherlands Lab has collaborated with patients and the public. I'm going to use this workshop that you can see the poster for here as the case study, and I'm going to talk you through all the steps we took to make sure we meaningfully involve patient and public throughout. I'm just going to quickly start with a bit about me. That's a photograph of Southampton. So I'm currently in Southampton, and I'm a health psychologist and senior research fellow at the University of Southampton. I'm part of the internationalisation work package of the ELSA AI Lab Northern Netherlands. And also I work in the ELSA Lab in the National Institute for Health Research Biomedical Research Centre in the Data Health and Society theme, and that's at Southampton as well. My research interests broadly are around new technologies in healthcare, and more focused, my research is around communicating genetic information in families. So I'm just going to introduce this workshop then. Like I said, we're going to use it as a case study. And so we used this, we wanted to address the topic of medical AI inclusivity, which is an important aim of the ELSA Northern Netherlands work and part of the responsible AI, making sure it benefits all. But because it's such a broad topic, inclusivity in medical AI, we organised this workshop to kind of explore some key challenges and come up with a research agenda. I'm going to talk you through the steps that we took. So the step that kind of runs along all of the work, prior, during and after, is the ELSA Northern Netherlands Citizen and Patient Advisory Board. I'm going to tell you a bit more about that. And then we've got these other steps. So I'm going to tell you briefly about a pre-workshop discussion that we did with public contributors in the UK. My talk is going to mostly focus on this. So it's a tool called Polis that we used to reach consensus among workshop attendees and patients and public. I will tell you briefly about how we involve patients in the actual workshop, and then tell you what the next steps were. So to say a bit more about this citizen and patient panel, so citizens and patients are a really important partner in the ELSA Northern Netherlands lab, and one of the ways collaboration is realised is through this advisory body. As you can see by the pyramid diagram there, we're trying to move beyond kind of traditional participation and engagement towards meaningful involvement and working together in meaningful ways. So I'm just going to go on to the next step now then, so this pre-workshop discussion we did. So this was done in the UK in December 2024. Our workshop took place this year in February. So I partnered with a patient and public involvement engagement officer from the University Hospital Southampton, and we had two aims. One was to gather public and patient opinions regarding how we develop and use AI in healthcare to make sure it benefits everyone, but also we wanted to explain how can we best include patient and public opinions in this 5-day workshop. And we were very well aware that it seemed too burdensome to ask someone to come to a 5-day workshop. It seemed burdensome to ask academics and researchers, but so we wanted to make sure we were kind of exploring other ways to do this. It was quite interesting working with the PPI officer because inclusivity in AI is quite a complex topic, and it took us a while to come up with this topic guide to make sure it was useful, it was meaningful, we were not kind of taking anyone off guard and really getting some kind of meaningful engagement. We ended up with 6 participants, and we tried to kind of do some pre-meeting work as well. So we kind of already sent them things like definitions of medical AI and an introduction to the topic, and we gave them some examples of some of the questions that we'll be discussing. So that's just like a little taster of what we did, and we're writing a paper at the moment that will tell you a lot more about what we did there. So this is the focus of my presentation. So it's this pre-workshop Polis that we did. So I'll tell you a bit more about Polis, but we wanted to use it to increase collaboration and reach consensus. So Polis is a deliberative tool, and it collects, analyses, interprets feedback from large groups of people in real time, and it uses advanced statistical methods. And the reason we use this is, well, largely because of the research that I've done in the past on complex topics. Often you just get very polarised views. People have kind of these dichotomous opinions, and then you can't really get anything in the middle. But the other reason is that we had this 5-day workshop on a very broad topic, and we wanted to come up with 3 key challenges, and we wanted to make sure that we were asking all of our participants about that. So we asked our workshop attendees, but we also wanted to make sure we asked our patient experts and our public contributors. So I'm just going to show you what the Polis actually looks like. So it has this title. So ours was in this 5-day workshop about inclusive medical AI. What do you think is the biggest challenge to focus on? We gave everyone a definition of what we meant by inclusivity and what we meant by artificial intelligence. The Polis works by showing people statements that they agree, disagree, or pass on, and we wanted to make sure that we impressed on people that it might be tempting to agree on everything, because probably everything is quite important, but actually save your agrees for the topics you think are the most pressing challenges. And as I said, the respondent is faced with these statements, which they can click agree, disagree, and pass on. Very importantly, the respondent can add their own statements. How did we come up with the actual statements? So when you make a Polis, you seed it with statements. We seeded it with, I think, 16 of our own statements. But also we made sure that that was based on what our workshop attendees thought was important. We did a pre-workshop survey where we asked them questions around what does inclusive medical AI mean to you, and that informed our definition. We asked some questions around what they thought was necessary to realise inclusive medical AI and topics related to that. We spent some time looking through this data, and that helped us refine the statements that we then put into the polis. And then we looked at the patient polis and the workshop attendee polis and cross-checked everything to make sure that we came up with 3 challenges that represented the most important ones across these 2 groups. These were the 3 challenges which Patricia will tell you a bit more about in her talk. Why did we use polis? We used it for many reasons. One is it's both quantitative and qualitative. It's more dynamic than a fixed question survey and a focus group. People can add their own responses in, so you're not fixed. It's anonymous as well, so when we're thinking about engaging patients and public, kind of trying to ease those influences of like power and perceptions of some people being more knowledgeable than others. It was super quick to use, so quick for us to make it and quick for people to use. And it reaches a wide sample. But also participants get to see theirs and other responses, and we encouraged our respondents to visit the polis several times so they can vote on any other statements that were added. Just to briefly tell you then how we worked to make sure that our patient and public voices were involved in the actual workshop. I don't expect you to read any of this, but it gives you a kind of idea of the busy week we had. This is our kind of schedule for our workshop, very busy, lots of different things going on, but it was on the second day, so the Tuesday, that we invited our expert patients to come, and they actually spent the whole day with us. They worked on a couple of different activities, and they were included in the group, and our aim was to include them as equally as all the other workshop attendees. I should probably say a bit more about that. So we had 3 public members. One of them was recruited from the Citizen Advisory Board, and actually we consulted with that board too on how best to involve our expert patients. We actually did a extra piece of work after our workshop where we did an evaluation with these expert patients. We really wanted to check in, it was new to us and probably new to them, about how they felt about being involved. Overwhelmingly, we found that the expert patients involving them made them feel valued. They said they felt respected and taken seriously. They appreciated the composition of the group. They liked that it was international and diverse. They felt equal to the academic researchers, which was really something we had in mind and really obviously wanted to avoid. And it also interestingly changed their perspectives. They talked about how it transformed their views on AI in healthcare from maybe a sceptical one to maybe a bit more positive. And also, interestingly, improved things like their self-image and confidence in working with medical professionals, and because to such an extent that they had a good experience, and also added to their understanding of AI applications in healthcare, and increased their trust in professional and patient collaboration going forward if ever they were invited to do things like this again. So to conclude, we found that our pre and during workshop activities they demonstrate a model for incorporating meaningful patient and public involvement in discussions regarding inclusive medical AI, but also we feel like this would have applications to other complex topics as well. We felt like the polis tool proved effective for use with patients and public groups, and actually this tool, when we started to investigate it, we could see that it had been in use in local governments, but it hadn't actually ever been used in healthcare that we could see, so it was interesting for us to experiment with that and draw the conclusion that it is just as applicable in healthcare. And our kind of main thoughts really are that we must continue to do this, to meaningfully work alongside multiple stakeholders, whilst also balancing this careful consideration on the burden it would have on patients and public. That's my presentation.
Thank you, Lisa. For the sake of the time, we will continue with Patricia. Patricia will tell you a little bit more about the results of the workshop that, oh sorry, the wrong button. Patricia will explain a little bit more about the results of the workshop. That Lisa just introduced. I think this is yours. Yeah. Oh, what's happening? Try it again. I think this is the correct one. Or is it?
You have to stop this one. Yeah. Can I?
Yeah. Oh, the other one's still open.
Yeah, yeah.
Okay. Patricia, the floor is yours. You can do it better than I can.
Okay. This one. Is it showing the slides fine? Yeah? Perfect. Okay, great. So my talk will continue on what Lisa has already presented about the workshop that we conducted in the Lawrence Center, but most importantly, the solutions and the requirements and what we came up with after the workshop, that is a new framework for medical AI inclusivity that we now call Prefer It. So first of all, just a little, if this moves, it's not moving. Okay. Just a little bit about me as well. So I'm a medical doctor. I am originally from Portugal, specialized in public health. But right now I live here in Groningen while doing my PhD in the ELSA lab, Northern Netherlands. And so this is already been talked about, especially by Joël, but just to recapitulate why this is important. So we know that a medical AI has a lot of potential benefits. It can improve diagnosis, it can personalize treatment, it can enhance patient experiences, it can optimize resources, but there are it is very much aware that we know the risks of medical AI, especially because it can perpetuate biases, it can cause patient harm, and it can increase the inequalities and the disparities in healthcare, particularly in groups that are already vulnerable or underserved in healthcare. And that's why talking about AI inclusivity is such a hot topic and important for us in the ELSA lab. A lot of disciplines address, in a way, inclusivity and addressed in a way fairness, but what we see in the literature is that this is done in what we call a fragmented approach. So to give some examples, we know, for example, that medical informatics looks at addressing biases in a more technical way. We know that ethics and social sciences looks at very important principles of human rights or dignity, but sometimes in a very difficult way to make it concrete and pragmatic for healthcare. We know that in healthcare, in public health, patient-reported outcomes, it's something that is important, but it's very much focused on high-income contexts. So we see that's lacking something that is integrated and systemic and with a vision that integrates all the phases of the AI life cycle and all the structures of the AI ecosystem. So we also know that a lot of priority is given to the phases of design and development in the AI life cycle, and a lot is done into the structures of data, system, and process, but not a lot in humans or stakeholders and governments. So this was the beginning of our conversation when we talk about AI medical inclusivity. And because of that, we organized this transdisciplinary workshop, as Liz has already presented, I want to mention that this workshop was very much focused on Europe, so this is also a limitation, but we managed to gather 16 nationalities on this discussion with 37 experts with many different backgrounds, and as you can see, also with 3 patient experts during at least one of the days and 1 patient advocate during the entire week of the workshop. And to organize this workshop and to really, for you to understand how we come up with the outcomes and the requirements for inclusive medical AI, we based our method in the design thinking methodology, which very simply just we start with a problem, which is a very big problem, very complex problem, that's inclusive medical AI, and then we start to diverge and to think about what is really out there, what we really know about that, and then make it more concrete into what we call the 3 key challenges. So that's the process of the double diamond. It's really to do this process of divergence and convergence. And then the second diamond is to think about solutions and requirements. Again, think about everything that's out there and to think about what we can make it concrete and pragmatic. But to make this more real and for you to understand, let's look at Tim. So Tim is 40 years old and he suffers from chronic back pain. But as well as this, he also suffers from hidden mental health issues. And this makes him have already some challenges and limitations, especially with distrust of the health system, because he feels that whenever he goes to a healthcare provider, he is patronized, he's not taken seriously, and the only thing that he really wants is to keep working, maintaining his health, and to be considered a partner in his healthcare journey and not just a problem or a data point. And, well, the hospital where he goes just found out that, just implemented a new AI tool that's amazing for patients with back pain. And this means success for developers because the AI tool is accurate. It means success for the hospital because it means lower costs. It means also success for the regulators because it's safe and compliant. But for Tim, success of the AI tool would mean to be a tool that he can trust, that can feel like it's doing holistic care and addressing all his patient needs and lived experiences. So as you can see, there's already here a misalignment between what is this AI tool and what is the team's experience. So this is it's just an example for you to know. This AI tool only focuses on clinical and imaging data. It doesn't really address the mental issues that Tim faces, his lived experience, his social determinants of health, and in a way, his patient needs are not really met. So this is just an example for you to see, because these sort of stories in this sort of storytelling and patient journeys was what we also worked on during our workshop with the patients, because it's easy to think about everything that's theoretically in medical AI inclusivity, but to make it concrete for the patients and what they're living, that's the hard part. This story of Tim was the story of the Challenge B, designing data collection practices to promote fairness and prevent inequalities, but of course it also has some bridges with the other 2 challenges, so integrating the lived experiences and stakeholder voices across the AI lifecycle, and fostering regulatory frameworks to uphold human rights and promote inclusivity. What was interesting to see was that the group was working in 3 different challenges, making it concrete. Why is this a challenge for AI medical inclusivity? And although they were working in different challenges, when they addressed the problem itself, they saw similar problems in different challenges. So for example, all of them identified there was a misalignment between the lived experiences, the needs of the patients, and the incentives of different stakeholders out there. They also identified there are structural and procedural barriers that limit the co-creation and limit the integration of patient voices and patients' opportunities, and this in a way translates the need to better reflect the lived experience and the social determinants of health when thinking about AI in healthcare. And okay, we've come to the real details of the AI medical inclusivity and the challenges about these three challenges. But we ask the group, can you come up with solutions? Can you come up with requirements? Because, as I said, in the literature review, what we see is we're still missing a pragmatic approach. And the group identified over 180 solutions and requirements for inclusive medical AI, concrete ideas to advance inclusive medical AI, which we now call our framework that's Prefer It. So basically, Prefer It is a set of co-created foundational requirements to guide inclusive medical AI in healthcare. And as you can see, we have one letter for each of the core principles of Prefer It, but most importantly, this is a tool to be pragmatic and to think about inclusive medical AI in healthcare. So we now then, after the workshop, we mapped the preferred requirements into the structural layers of the AI ecosystem and into the AI lifecycle phases. And we did that in this sort of double axis. So you have in the axis the structural layer and the y-axis the phases of the AI life cycle. And what is important to note about this framework is, of course, the boundaries can be discussed, and we can probably map each of the preferred requirements into different spaces, depending on also your perspective and also your background. But that's the relevance of doing this exercise is not really of having a definite categorization for preferred into the double axis, but to really think and use it while you are implementing a solution that really considers AI medical inclusivity. So let's look at an example, a concrete example, looking back at the story of TIM. So we know that one of the problems with TIM was that there was a misalignment between incentives. So one of the solutions that come of the 180 that came from the workshop was incentive alignment. So we can map incentive alignment into the participatory and co-design approaches, the P of Prefer It, real-world validation, the R, but also in some of the structural layers of the AI ecosystem. So this involves humans, this involves governance, this involves the entire AI system, and different stages of the AI lifecycle, evaluate, implement, and monitor. So this is just an example with the team story, but as you can see, if we think about Prefer It, then we can map the solutions, and we can think about medical AI inclusivity and make it more pragmatic and not just something, again, a bit high level. Of course, this still has some gaps that we would like to address. We know that when we're talking about AI and we're talking about healthcare and policy changes, this involves a lot of complexity and a long time to change things. We also know that we are still talking about making it concrete, implementing ethical principles, and that's also a challenge. And we also know that this is difficult to balance when we're talking about different values with different contexts and talking about making something standard or one-size-fits-all. It's also a challenge. But we also consider that these are not just challenges or gaps, but also opportunities to think about how to address and to test Prefer It in next steps. So we know we suggested to have Prefer It in terms of policy alignment, in terms of education tools and public engagement, and also education of patients, and changing also how we do funding criteria, for example, to include inclusivity as a metric for healthcare and AI in healthcare. So in terms of next steps for our research, we aim to test Prefer It in real-world projects and include different contexts and different stakeholders besides the 5-day workshop that we did, and especially have here, very importantly, user and patient feedback, because as you've seen also with Liz's talk, this was also something that was transformative. This is an ongoing project. We aim to finish it by hopefully this month with a paper, so I also invite you to keep tune in for updates on the paper that we're going to publish about the work that we did in this workshop. And I would like to thank everyone that was involved, all the co-authors. As 37 experts, it's a lot of people, but we managed, and I hope to have news very soon. And that was it for my side. Thank you.
Thank you, Patricia. Are there any questions for either Lisa or Patricia about the workshop?
For the first speaker, but maybe also for Patricia, I was wondering, how do you prevent bias in the patients or public people you involve? So you're looking for voluntary participation, right? So how do you know that they do represent a broader group of stakeholders?
Lisa, did you get that?
Yeah, thank you. Yeah, it's a really great question, and it's something that I have grappled with often. So, for instance, if you take the UK group, they were recruited through an existing network. So the hospital in Southampton have a PPI network, and you can see that there are issues there straight away with people being kind of expert PPI. And it's definitely something that I am addressing in like my future research as well, that kind of also gathering views from people that aren't kind of in that setting. And I think yeah, it's a great point, and yeah, something that needs more thinking about, but also when we're thinking about like this meaningful involvement, especially with something like this workshop, we kind of went on the side of people that were a little bit experienced. This was a bit of an experiment for us in the ways that we were involving patients and public, but I really take your point, and it's something that I'm looking at addressing in the future.
Yeah, maybe if I may add, because I think this is always a challenge. So if we talk about the ELSA Lab Northern Netherlands and also about the recruiting of the patients who participated in the workshop itself, yeah, we try to work also with different organizations. So for example, also for the workshop, we work together with VAROS, who has a lot of skills and experience also with regard to low literacy, for example. And we also work together with a foundation which is called Sterk in Armoede, Strong Out of Poverty. And they they really, how do you say that, educate people to who have grown up in poverty, and they are giving education, and they learn to use their experience and translate it to concrete practices. So they really have also a lot of communication skills. So that's also what we do, and because it's always difficult, because very often you get indeed the more higher educated people. So you really need to try to work with the organizations. For example, also that's why I also think it's interesting we work now together with Hadi, with Vluchtelingenwerk, so you can really reach out to different groups in that respect. And I think, Simone, you wanted to add to that?
Yes,
Yeah.
thank you. Well, of course, in the Dutch Patient Federation, there is a lot of experience with respect to this aspect of patient representation. Is always a challenge. I mean, I don't want to refrain from that, but what we did, and I find it very interesting, that's why I raised my hand, is that in our guideline project, we had 3 members of a patient organization in the guideline working group. And in fact, we, invited, but you could nearly unfriendly say forced them to work with the local groups. So the 3 of them, they live in different cities in the Netherlands, one in a rural area, a small city, and then Amsterdam and Amersfoort. And what I liked about that is that they really learned a lot from the very diverse groups that they so we try to let them be quite diverse, but also they needed and they really changed their view on bridging language barriers a lot. I mean, for example, the fact that people are often, well, there's many cases where people are simply sent away because they didn't bring someone themselves to do the translation in the medical context. And well, they heard that much more clearly, so it strengthened them a lot in taking their position in the guideline group. It's a group with medical doctors, with interpreters, and so on. So they needed strength, and that's also what it is about. It's representation. It's about strengthening them, and then also, of course, a chairman, for example, who really gives them the floor as well.
Thank you for this addition, Simone. Any other questions? Otherwise, I'm going to share my screen again. So we had it's always almost 5 o'clock, so we want to close also this meeting. I want to really thank the different presentations. I hope also for the audience that something new was learned and people got inspired. If you want to know more about DASH or the ELSA Lab Northern Netherlands, you can go to our website, and also DASH has a newsletter. You can subscribe to that, and also that newsletter is a monthly newsletter, and that will inform you about what's going on, both in the UMCG as well as outside the UMCG, about AI initiatives, including initiatives from the ELSA Lab. For the last program, of course, we have some drinks. I was told that the drinks are around the corner, and there's a last dilemma mentioning. But first of all, I want to mention that this Friday there's another event which might be also interesting for this audience. This is also about access to digital healthcare. It's also here at the UMCG, so you're more than invited, and you can still subscribe to that. I also want to thank Wieke Bouwers for the organization of this event, Frank Scheur for helping with the communication, and of course you for being here. And then we have a last dilemma. So do you stay for a drink and be home a little bit later, or do you go home and miss the opportunity to have drinks and to talk